All right, everybody. Thank you for joining us for today's webinar with Dude Solutions and MSL Healthcare Partners. My name is Earl Lang. I am the Industry Marketing Manager for Healthcare here at Dude Solutions, and I'll be moderating today's event on navigating the impact of CMS adoption of NFPA 101-2012. Really quickly, just want to go over a few housekeeping items today. We certainly appreciate you guys joining us, but just kind of want to set the scene for the webinar. Phone lines have been muted for participants today. That's more just to eliminate background noise than anything. We don't want to let that discourage you from submitting questions though, so please use your chat box for that. If we aren't able to get to your question today, don't worry. We've got your information and we'll follow up with you directly afterwards. And the biggest thing I can't emphasize enough today is that if you would like a copy of the slides that we're going over or the recording of today's presentation, we're certainly happy to provide that to you. All we ask is that you fill out a short survey after the webinar that's going to be emailed to you, and then we'll follow up directly with whichever you'd like. So be on the lookout for that email after the conclusion of today's event. So very briefly, just wanted to go over the agenda for today's webinar. That way you guys have an idea of what to expect. We're going to go through a very brief introduction period to introduce both Dude Solutions and MSL to the audience for those of you who don't know us. And then we're going to get into the bulk of the presentation, which our presenter Wayne's going to take us through. We know that's what many of you came here for today, so that's where we're going to spend the majority of our time. That's a great time where if you have a question come up on what we're going over, use your chat box to ask us so we don't forget about it later. Wrapping up, we'll do a very quick review over some service offerings that we both provide from a DSI and MSL perspective, as well as give you an idea of some of the events we're thinking about down the road and a way to reach out to us if you're interested in contacting us for any reason. And then last but not least, the part that most people look forward to is that live Q&A. We'll take about 10 minutes to answer any questions that have come in throughout the webinar. So to kick things off today, we wanted to take that 5 minutes to introduce ourselves just so you have an idea of why we're talking about what we are today. Dude Solutions is a partner in software and service offerings for smarter operations for all types of facilities. Obviously, we're going to be talking about healthcare today, where we provide cloud-based solutions that help you manage assets, improve workflow, and make those data-driven decisions that are also important within our organizations. We've got about 15 or so years of experience now. As a company, we're based out of Cary, North Carolina, and in that time have gathered over 9,000 clients, approaching the 10,000 mark here, getting pretty close to that. And our overall mission as a company is really to empower our clients and our people to combine innovative technology and operational insight to transform the places we learn, live, heal, work, and play. So we are dedicated to serving healthcare facilities specifically, though. That's one of our key verticals that we do serve. About 9 years ago, when we were known as Facility Dude, we launched cloud-based operations management for healthcare at that time. Since that time, obviously it's been a while. We know the landscape of healthcare has been undergoing many changes. Healthcare organizations are unlike any other type of facility out there. Today, the unpredictable nature of both patient care coupled with the strict governance over processes can certainly be a daunting combination. Nobody understands that better than you guys who are on this webinar today. This complexity is exactly why you need a partner who understands all those complexities as well. And with over 1,000 clients in healthcare alone, we've gotten a lot of feedback over the years and taken our industry expertise and built a state-of-the-art CMS and operations management solution designed to specifically meet the unique needs of both you, your organization, and the healthcare industry as a whole. Quick note on that 400 plus implementations you see down there at the bottom in 2016. That has a lot to do with the Works Hub, which is that healthcare specific CMMS I referenced just a second ago. It was built specifically for the healthcare industry to help you manage your facilities and maintenance operations and compliance program. Anything from corrective to preventive maintenance, planned maintenance, asset management, risk assessment, and alternative equipment maintenance. It's built with mobile functionality, including barcoding that will help you with PO and inventory, capital planning, and what most people get very excited about are the surveys, inspections, and an EOC rounding component, which most people we know are still doing on paper, so they've been very excited. We're kind of giving a way to do that mobily in the field. All that rolls up through extremely robust reporting. So that's really where we're kind of tying in our relevancy to today's topics. Really, we just wanted to give an opportunity to relate what's going to be discussed today. I thought a little bit of that background and context might be helpful on why we're talking about a lot of these topics today. So what I'm going to do now is I'm now going to kick this over to Wayne to tell us a little bit about himself, MSL, and then let him jump into the content I know so many of you guys are eager to hear about today. So without further ado, I'm going to kick this over to Wayne Klingelsmith to take us through today's presentation. Wayne?
Thank you, Earl. We have a great deal to cover today, so I'm going to go through rather rapidly. Hopefully, if you don't have a good work order system at this point in time for preventive maintenance and scheduled maintenance, you certainly should take a hard look at DUDE. But a little bit about MSL. We started up about 8 years ago, and most of us have spent time in the healthcare industry. I was over 30 years in healthcare facilities management. Former president of the Society for Healthcare Engineering, ASHE, and you can see the information there. I'm not going to spend a lot of time on that. Also, just quickly what some of the things are that MSL covers. We do quite a few mock accreditation surveys, about the fifth one down there, and work with facilities on that whole regulatory compliance side of things. However, we work with facilities management in any form, even providing assistance if a facility is between facility managers. Okay, so let's get into the detail. Some of what we'll be covering today, first of all, we'll look at the significant changes affecting us in NFPA 101 2012, and then assessments that NFPA 99 requires that we do. And I want to spend some time talking about the CMS K-TAG document that came out in mid-January, I believe it was, and I use that a lot as a training tool for folks who are not familiar with codes. It's an excellent document, I think. So we're going to spend a little bit of time there. We're going to look at top 10 Joint Commission findings very quickly, and then spend a little bit of time talking about some of the condition level and immediate threat to life findings that Joint has had in the past year or so, and we'll talk about that. And then some of the changes in the environmental care and life safety chapters, both elements of performance that were deleted as well as new ones. We'll talk just briefly about the SAFER matrix, and then look at the environmental care life safety document list and fire drill matrix, and talk about that just a little bit. First of all, I want to make sure we're on the same page. You're all aware that CMS adopted the 2012 edition of the Life Safety Code effective July 5th. What that means is facilities that were approved for construction prior to this date are considered existing healthcare. So basically all of us are existing healthcare. You may even have a building that's under construction at this point in time would be considered existing healthcare when it's completed because it was approved for construction by your local state organizations or AHJ prior to that July 5th date. So anything that gets approved by your state AHJ after that July 5th date becomes new health care subject to Chapter 18, and we'll look at some of the differences a little bit later on the slides. But one thing we should make you aware of right now, if you meet new, you cannot reduce to existing. What that means is existing healthcare, you're allowed only a 4-foot wide corridor if that's the way your facility was built. I don't run into that very often, but every now and then we'll find a hospital with less than 8-foot wide corridors, and they're concerned because they don't meet the 8-foot clear corridor width. They don't have to for existing. However, if you have an 8-foot wide corridor, you cannot reduce it down to 6 or 4 feet just because you want to. You must maintain that 8-foot wide corridor. Another thing to look at is on existing healthcare, a storage room or soiled utility room, if you're fully sprinkled, does not require the walls to go from deck to deck. Does not have to be 1-hour rated walls. They have to be smoke-resistive walls. And the door does not have to be 45-minute rated. It only has to have a closer on it and be a substantial door. So big, significant difference there too. Okay, let's look into some of the changes that were made when CMS adopted this as part of their conditions of participation. They again prohibited roller latches, which is what the stance they had taken before under the 2000 edition of the code. Basically, no change there. We cannot have roller latches on doors to corridors or rooms containing flammable or combustible materials. The other thing that high-rise buildings must comply with by 2028 is to be fully sprinkled. Many states have required facilities to be fully sprinkled, already, but there still are quite a few out there that are not fully sprinkled. Under new construction, window sill heights 36 inches above the floor. A big one for ambulatory healthcare occupancies who are ambulatory surgery centers per se. If you are a 1 or 2 room ambulatory surgery center and you flew under the radar and called yourself business occupancy in the past, now it's 1 or more incapable of self-preservation rather than 4 or more incapable that qualifies you as ambulatory healthcare occupancy rather than business occupancy. What that means, ambulatory healthcare occupancy rules are very similar to healthcare occupancy in NFPA 101. And then the other thing that CMS did is specifically adopted the Healthcare Facilities Code, NFPA 99, the 2012 edition. In the past, it was adopted by reference through the Life Safety Code, but this time they specifically adopted 99. Now, some of the changes, of course, the categorical waivers that we had several years back, this one came out in 2012, was basically for nursing homes initially. Hospitals, when this first came out, still had to go through the long process to adopt it through a waiver. And then later on, it became a categorical waiver where you simply had to adopt it in-house. I'm not going to talk about the individual items here because you should be aware of them, but let me know if you do have any questions on it. The next thing is on the relative humidity. That categorical waiver came out in April of 2013. Actually, back in 2010, I believe it was, Joint Commission went from 30% relative humidity, dropped down to 20%. So the range was 20 to 60 rather than 30 to 60 back in 2010. CMS stayed at 35% as their low end until this waiver came out, allowing us to drop it to 20% on the low end. Now that we've adopted the 2012 edition of NFPA 99, we no longer require the categorical waiver. However, there's been some new data that's come out saying we need a risk assessment if we are going to allow our anesthetizing areas to go down as low as 20%. We're going to allow them to go below 30%. That's because there's some sterile products and supplies and also some medical equipment that the manufacturers have not allowed them to be, they're not listed to go below 30% relative humidity. And one I can think of in particular is medical equipment as an ESU unit that was designed for flammable anesthetics. The manufacturer strictly says they're not allowed below 30% relative humidity. So it's required that you go through a risk assessment process to document that you, in fact, feel it's safe to lower your bottom range down to 20%. Okay, and here's where that came from. January 2015, you can Google, I think, this document if you want to read it in detail, but it recommends that facilities assess the impact of that lower relative humidity. Okay, the other 7 items that were part of a categorical waiver that came out in August of 2013, you can see here very quickly, these are now code. You no longer need the categorical waiver for these. And here's the last 3. Suites is a big benefit to us if you have an ER or other areas where in the past perhaps they didn't allow 2 direct exits from a suite or from the area. Now as a suite, you only require 1 direct exit to an egress corridor. The other exit can be through the adjoining suite. For many organizations, for their ORs as well as the ERs, that has allowed them to call them suites now and gain the benefit of it being a suite where you don't have egress corridors that must be kept clear for egress. The other thing on waste recycling, in the picture in the bottom corner, in the past, under the 2000 edition of the code, that would have been a finding, having a recycling container next to a waste container, because in total, we're probably looking at more than 32 gallons of waste in a 64 square foot area. So with the 2012 edition of NFPA 99, recycling materials are no longer considered waste, and so there's not a problem with what you see there in the picture. The other categorical waiver that basically goes away, however the information remains, is on power strips. And as we talk later about the K-tags, this happens to be K-tag K920, as you can see there. And just to be aware that power strips in patient care vicinity, that's within 6 feet of the patient, must be that UL 1363A or UL 60601-1, and that's for patient care related electrical equipment only. You can't plug in something that's non-patient care equipment. Any other power strip that might be in a patient room, but outside of the patient care vicinity, that 6 foot radius, must meet the UL 1363 requirement. Now, this is not just a patient sleeping room, but this is any patient care area around the building. So whether it's radiology or nuke med, wherever that patient may be, these same things apply if you're going to have a power strip, so and including the OR and so forth. Now, the last bullet is one to be aware of, that in non-patient care rooms, power strips meet other UL standards. So in other words, they don't have to be that UL 60601 or 1363. They can be anything that's a UL listed power strip, and I guarantee you that under the nurse's station or under desks at hospitals throughout the hospital, IT has put in power strips that were not any one of these power strips. As long as it's a UL listed power strip, it's okay. So that's a huge benefit for us moving forward. Okay, some of the changes that we're seeing in the 2012 edition of the code. Door assemblies tested not less than annually. This, I think, is going to be a big one. I think it's going to be a lot like the damper issue was, that we had not been testing our fire and smoke dampers back, what was that, 25, 30 years ago. Some of you folks may not remember that. But the first go-round as we inspected dampers, we had a huge number of repairs to make. I think we're going to find the same thing with doors. I think we're going to find doors with holes in them, frames with holes in them, improper hardware been attached, and we'll have lots of repairs and probably door replacements that will have to be made as we make this review. But after that, I think once that's done, I think then we'll be able to maintain them from there on out. The other thing is, we can't just have anyone do this inspection. It has to be someone that's been specifically trained. So if you're going to use your staff, make sure you send them to a seminar and you can document that so you can show that they've been trained to do these door inspections. A couple other new items, means of egress in an area undergoing construction or repair or improvement should be inspected daily. I think we've probably been doing that in our ILSM process, but it also says, the second bullet there, if you have an area where the construction site poses a greater degree of hazard than the normal to the occupancy of the building, you must have a 1-hour fire-rated temporary construction petition. Most of us put our construction petitions from the floor up to the underside of the lay-in ceiling. That's not going to fly if we're doing any kind of significant work in the construction area. So if we're taking walls out or anything that's other than perhaps aesthetic changes, painting and a wall covering, it looks as if we are going to be required to have a 1-hour rated temporary construction petition, which also means a 45-minute labeled door with closer going into the construction area. So big change there on that particular item. But Chapter 43, which is again in NFPA 101, 2012 edition, this is a brand new chapter, and it's where the other item came from out of this chapter that we just talked about. This is going to help us. This says for existing healthcare occupancies protected throughout by a sprinkler system, where a change in use of a room or space not exceeding 250 feet results in a room or space that is described by 193215 number 7, that happens to be a hazardous area. But it says the requirements for new construction shall not apply provided the enclosure meets the requirements of and so forth. What that means is if we take, for instance, a patient room and we convert it to storage, instead of being required to replace that door with a 45-minute labeled door with closer, and instead of being required to take the walls up deck to deck and rebuild them as 1-hour rated walls with 5/8-inch sheetrock on both sides, this says that even if the walls stop at the ceiling, if we're fully sprinkled, it's okay to make this change as long as we put a closer on the door. So we have to look at the existing healthcare occupancy chapter and look at a hazardous area and see what's required there. You'll see that it does not require a labeled door. It's simply a substantial door with a closer. And if you're sprinkled, it does not require 1-hour rated walls deck to deck. So this is a huge benefit for us in existing healthcare. Okay, we're going to talk a little bit about NFPA 99, and it basically was completely rewritten. Instead of being occupancy-based, everything in 99 now is risk-based, and we'll describe what that means in a little bit. It says that wet procedure rooms require, well, we'll get into this in a minute, but it requires either GFI or isolated power unless you do a risk assessment. CMS wanted to include smoke venting as a requirement for ORs. NFPA 99 had taken that out, and CMS reneged and decided they'll leave it out and not require it also. So smoke venting from operating rooms is not required. There are some cylinder storage changes, and of course power strips. They give the detail that we just covered a minute ago. Okay, risk-based. So 99 now is based on the risk to the patient based on the procedure, whether it's performed in a doctor's office or a hospital. So there's always been concerns in the past that a physician practice could take something out of the hospital and start doing minor surgery or doing a procedure in his office and would not have to comply with all of the requirements of the FGI guidelines. Now he does. This basically says that if a failure of a utility could cause major injury or death, it would be considered a Category 1 location and would have to follow what NFPA 99 calls for in Category 1 locations. If failure of a utility could cause minor injury, then it would be Category 2, and so forth. So you'll have to look at 99 to see just how that impacts, but it's based on the systems itself serving particular room or space. Now, in addition, as I talked earlier, we must have relative humidity risk assessment written for a surveyor saying that we are allowing it to go below 30%, and we've got a completed written risk assessment. But in addition, we're required to do risk assessments on our gas and vacuum systems, our electrical systems, HVAC systems, electrical equipment, and gas equipment. Now, Joint has not specifically stated it's required. CMS has alluded to the fact that a risk assessment is required for existing healthcare, and as a matter of fact, HFAP, who is an accrediting program similar to Joint Commission, is requiring that facilities do a risk assessment of their existing systems. And I talked with Brad Keys, who's the George Mills for HVAP, and he says, in fact, they did require it in their standards. They are and will be citing facilities if they don't have a written risk assessment on existing systems. But he agrees with me that it's really not necessary. This was designed for the risk assessment should be done for new construction only, not for existing systems. Basically, your existing systems were originally designed and constructed for acute care hospital. So as long as, and I'm reading that bullet below the gas and vacuum systems, as long as the existing systems, are in strict compliance with the provisions of the code the time they were installed, this code will permit them to be continued in use. So the concern is there's a little bit of confusion here, and I think it's going to take maybe a month or two for it to get straightened out. If you are HVAP approved or HVAP accredited facility, you may want to do a risk assessment. If not, I'd probably hold off on it. But you do need that relative humidity risk assessment. Another risk assessment you may need if you don't have isolated power or GFI interrupter circuits in your ORs or anesthetizing locations, you will need a wet location risk assessment. So be aware of that. And ASHE has one on their website that you can pattern after as you do your risk assessment. Okay, so let's talk about some of the changes based on the NFPA 99-2012 edition. For pipe medical gases, articulating booms in your OR must be tested every 18 months. Actually, it's a pressure test requirement. And that's because we find that the hoses and flexible connectors actually may leak after being moved around as often as those booms get moved. So that's probably a good thing to do. Also, we're requiring medical gas systems to be tested annually. Most organizations do that, and even though it was not required previously, now it's actually a requirement. We must also have an inventory of all of our outlets, alarm panels, zone valves, and shutoff valves. And the biggest thing is locations containing central supply systems, meaning where your manifolds are for your high-pressure gases, or cylinders containing only oxygen medical air, must have their doors labeled medical gases, no smoking or open flame. And that's something that they are, as of January 1st, they have been citing organizations. So make sure you get that signage installed. It must be, you must be able to read that signage. I believe it's from 60 inches from 5 feet away. And then medical gas storage. This is a new one that Joint Commission came out. It's basically a clarification, I guess you would call it, but it's a significant change or major change for us. Came out February the 10th. And basically it says that any oxygen E-cylinders in a smoke compartment that are not in a fire-rated enclosure must be considered full whether they're empty or not. So basically what that's saying, we have told staff in the past that you can have 12 full oxygen E-cylinders in the smoke compartment that don't have to be in a fire-rated enclosure. In the past, we were just counting the full cylinders. We were not counting partial or empty because Joint Commission said partial was the same as empty and did not need to be counted. They've now come out and changed that and said that all cylinders need to be counted in that 12. So we're now counting partials and empties and full in that total count of 12 in a smoke compartment. Now, if you are storing your cylinders in a hazardous area, clean or dirty utility room, and it's a 45-minute rated door and so forth. And as long as you're 5 feet away from combustibles, if you're fully sprinkled, then you do not have to count those cylinders in that count of 12, because those are just the unprotected ones that are not within a fire-rated area. Or what we're seeing, some hospitals are actually installing fire-rated cabinets in their areas. But this was a significant change that Joint Commission came out with, and something we're going to have to go back and do some retraining with our staff at our facilities. All right, let's talk about the CMS K-tags. This is the document that CMS came out with just middle of January, related to the 2012 edition of the code. And looking at a sample page, this K362 covers corridors and construction of corridor walls. You can see they describe what an existing healthcare corridor wall looks like and is required to be compared to new healthcare corridor wall. And this one doesn't have super changes between the two, but many areas will find that existing healthcare construction is significantly has significantly less requirements than new does. Another thing I talked about earlier is it's a great document for training and educating our staff. This talks about gas equipment. So K923 tells us that if we have greater than 3,000 cubic feet of gas storage in a room, that room must meet all of the 1 hour enclosure requirements, plus it must be ventilated. So it must have a exhaust duct that comes down within, what is that, 12 inches off the floor? I forget what the dimension is. But it must be ventilated with that low wall exhaust. If you have less than 3,000 cubic feet, but more than 300 cubic feet, the storage enclosure simply must be a fire-rated enclosure and secure. And you must have your gases separated from any combustible materials by at least 5 feet if you're sprinkled, 20 feet if you're not sprinkled. And then your non-combustible construction having a minimum half-hour fire rating, again, that's in the existing healthcare if you're fully sprinkled. And then less than 300 cubic feet, that's about 12 E-cylinders. You can have them anywhere in the smoke compartment. That's 12 E-cylinders within a smoke compartment. And this does say that where you store them, you must have that signage we talked about a minute ago. In NFPA 110, a few changes. Now, NFPA 101 2012 edition references the various chapters of other codes and the dates that it references. So for 110 on emergency generators, it references the 2010 edition. First of all, it says the routine generator test must be made immediately after the acceptance test. That's kind of strange they're requiring that. You would think anytime within the month. Battery conductance testing is now okay in lieu of just specific gravity testing. That's a good one for us. It does require an annual fuel quality test per ASTM standards, and that's something that I've seen that price anywhere from $200 up to close to $2,000. Make sure that when you're working with your folks that are doing that test, they're not getting you for something over about $200-300 per tank. Monthly load test, you can't start your 30 minutes until after reaching operating temperature. And then, of course, with a load bank test, instead of being a 2-hour test, it's now a 90-minute test. Okay, real quickly, the top 10 Joint Commission findings the first half of 2016. They haven't come out with the full year, what the findings are. I'm betting they'll be pretty similar to this. Safe functional environment is a number 1 finding. Some of that has to do with temperature, relative humidity, and pressure differentials. It also gets into some other environmental issues that we can talk about later. Infection control is a number 2 item. EC 20501 is number 3. That's risk associated with utility systems, and that basically comes from pressure differentials in critical areas. Next one is life safety 020120, maintaining integrity of the means of egress. what we find is magnet locks on doors that are in exit egress corridors, and we'll talk about that in a little bit. And LSO 20135, providing maintaining systems for extinguishing fires, so that's fire extinguishers and some of those systems. The last 5 here, patient care is number 6. Number 7 is life safety also. Number 8 is life safety. Number 9 is managing risk related to hazardous materials and waste. They're looking hard at how we document hazardous materials going out of the building, who signs the manifest, have they received their DOT training, and so forth. So we're seeing more items there. That also picks up emergency eye wash station findings, and boy, lately I've seen almost every hospital there's been a eye wash inspection missed or some problem with emergency eye washes. Then the last one has to do with medical records. Okay, avoiding condition level findings. This is the big one that we're seeing more and more, and I think probably going into 2017, this is probably going to be our number one issue. Having appropriate pressure relationships and air change rates and filtration efficiencies, temperature and relative humidity in critical areas. So look at all the spaces they're listing here, operating rooms, special procedure rooms, C-section rooms, and so forth. Almost always have a finding when I do a mock survey at a hospital in one of these spaces. Many times it's in sterile processing, in the decontam room, and we can talk offline about why that's happening. They're following AMI guidelines, which have a totally different temperature requirement than the FGI guidelines. You need to follow the guidelines that the space was built under and then maintain those temperatures and pressures appropriately. I think that's enough said for that one. There is a separate EP now for non-critical spaces, so sold utility rooms, clean utility rooms, and the areas you're seeing here also require pressure differentials and maybe perhaps temperature and humidity monitoring. But for these spaces, it's not as critical, and it doesn't lead to a condition level finding as quickly. I suppose if you stack up a number of them, it'll go to condition level, but these should not go quite as quickly as the first group. Just one finding has taken hospitals to condition level. Okay, immediate threat to life. If you have a life safety deficiency and you've not completed an interim life safety measure, that will take you to immediate threat very quickly. So it's something that when you go through, even when you do your fire door inspection, if you're finding problems with fire doors, I would do an ILSM covering those items. And you might want to group those so that if you're finding holes in the door frame, that's minimal concerns in a fire situation. I would think you could probably go through, lump those all together and do the ILSM, but then say that no further measures required other than to repair it. Okay, means of egress not equipped with a latch or lock, or what we're finding here is that magnet locked doors and a means of egress, whether it's to lock people out of a department, for instance, to lock them out of OR, or to lock other areas, if it's a means of egress and an exit sign above the door, and there's a possibility that anyone can get to where that is, even though employees can badge swipe and get through that magnet locked door, if John Q. Public cannot, it'll be a finding. So we must have a delayed egress lock on that door, or look hard to see whether it's truly needed as a means of egress, and would it be possible to remove the exit sign and not create a 30-foot dead-end corridor. Basically, although existing hospital occupancy can have an unlimited dead-end corridor, if you create it because of magnet lock, you're limited to 30 feet because it would be considered under that new occupancy requirement, even if you had that magnet on prior to July 5th. Okay, next we'll look at some of the significant elements of performance eliminated. Safe Medical Devices Act under the Biomed Group. Environmental tours, both in patient care areas and non-patient care areas, are no longer required by element of performance. And then, of course, our statement of conditions, that information was taken out also with the standards. Some of the new things have been added. Fire alarm, fire suppression systems, there's a number of changes that were made, and you can look at that list. Also on generator testing, the weekly generator inspection was added, as well as that fuel quality check was added. If we go to, whoops, went forward too fast. If we look at the safer matrix, and other than be aware of this, there's nothing we really need to do regarding the safer matrix, but be aware if you were the hospital that this matrix happens to be representing, with so many things up in that upper right-hand corner, it's a problem. It's probably a condition level finding. It probably will move up to that. So they're probably going to come back in 45 days. So just be aware. You want to be in the lower left-hand quadrants if at all possible. All right, let's look at the Joint Commission's Environmental Care Life Safety Document List. And hopefully you all have a copy of this. This came out, if you don't have it, go to your Joint Commission liaison person at your facility. It came out in the Survey Activity Guide that was issued February the 6th. That's the Survey Activity Guide issued February 6th. It's at the very end of that document. So first of all, that red arrow is showing where life safety drawings now have specific requirements that be included on life safety drawings. Basically, what's in blue on this document is new or changed, but I'm just pointing out a few items. Where the red arrow is here, it talks about notification devices, AV devices for your system. Of course, you have to have them listed, but they've added door releasing devices to that. So that door releasing devices, that's not just your hold opens that hold your fire doors and smoke doors open. That's also those magnet locks that we talked about a minute ago that must release on a fire alarm. So be aware that those have to be inventoried and listed. And then actually the one above, the one below that red arrow, emergency services notification transmission equipment, that's going to your monitoring company when your fire alarm goes off. In the past, we had to test that quarterly. Now the requirement is annually, so be aware of that. And then lastly, on this sheet, we're looking at inspection testing of door assemblies. We talked about that earlier. That's now an annual requirement to be done. And on generator testing, there's a requirement that we do the weekly generator test, that upper arrow, and the bottom arrow talks about the fuel quality test per ATSM standards. I should point out one other thing on this. If we look up to the first line, EP1, it says battery-powered egress lights tested monthly. They've added visual inspection of exit signs monthly also. So even though that exit sign is not a battery exit sign, it's requiring your exit signs to be inspected. That's been in the code for quite some time, but no one has ever required documentation on that until now. And last, we want to look at the fire drill matrix that Joint came out with middle of last year. I would recommend you, again, download this document and use it to record where your fire drills are or took place. What they're looking for is the location, of course, the day of the week, and the date and time. They want to make sure that you are not holding all of your third shift drills at 6 o'clock in the morning. It needs to be spread out over that third shift, for instance. And, of course, day of the week also includes some weekend drills and so forth. So I think that's about it. If there's questions or if I can provide you with any copies of some of these documents, please feel free to email me. But I'm going to turn this back over to Earl Lang. Earl, are you there?
I sure am, Wayne. Thank you very much for running us through that. That is quite impressive that you got through all that robust content in such a short amount of time. So great job with that. I'm going to just have a couple quick reminders for everybody, and we're going to kind of segue into the Q&A. Now's a great time to submit those questions. I just want to reiterate to everybody that if you want a copy of the slides, or if you want a copy of the recording, we're going to send out that post-webinar survey that will go out shortly after the webinar, so be on the lookout for that. Fill that out and we'll get you a copy of what you're looking for. You can also join us for upcoming events down the road in Q2. We've got some topics listed there that we're thinking about topics. If anybody thinks that those pique your interest, definitely let us know and reinforce that point. We're going to be exploring possibly talking about some of those. And another point on the surveys, the reason we're really emphasizing you take those post-webinar surveys is not only to get a copy of the recording or the slides, but it also gives you an opportunity to provide us feedback on what you'd like to hear about later this year. So we hope to get some great responses from you guys about what you'd like to hear about, and that gives us an opportunity to actually go and present on something that you've suggested. So we take those ideas very seriously and really encourage you to fill out those surveys for that reason. If anybody would like to reach out to myself or Wayne if you have any questions, our information, phone numbers, email, and websites are listed there. Feel free to reach out if you got any questions about any product-related stuff that we didn't cover today. Wayne took us through some great thought leadership and industry knowledge that is invaluable to a lot of you. So I'm sure he'd be willing to answer any questions directly that we don't get a chance to answer today. So we have had a plethora of questions come in, so being that we've got about 5 minutes left, we want to just be conscious of everybody's time and go ahead and segue into this Q&A session where we can get as many answered as possible. Just a reminder, if we don't get to your question today, we will follow up with you directly afterwards to make sure that gets taken care of. So Wayne, one question we got is that our IT department currently uses UL-listed plug strips under desks and at nurse stations throughout the hospital. Do those need to be UL 1363 and hospital grade receptacles?
Good question. And if I would have, before I got this CMS K-tag document, I would have said, yes, I would certainly recommend that they be that. But based on what CMS is saying in this K-tag document, they simply have to be UL listed. There's no requirement that they be hospital grade. As you may know, hospital grade receptacles are required in patient care areas only if you don't want to test your receptacles on an annual basis. If you're not required to have hospital grade receptacles in patient care areas, but if you do have, you're not required. Yes, you're not required to have hospital grade receptacles in patient care areas, but if you don't, then you have to test your receptacles every 12 months. If you have hospital grade, then that's not required. So, but as far as the plug strips under desks anywhere around the hospital, other than in patient care rooms, they can be just UL listed plug strips. They're not required to be hospital grade, and they're not required to be UL 1363.
Perfect. Great response, Wayne. Thank you. Have another one that's come in here. We've included fire door inspections with our building maintenance program, or BPM, for the past 8 to 10 years. Will these inspections comply with the new fire door inspection requirement that you discussed earlier?
Boy, that's a great question, because most folks are going to think that, hey, we've been doing this for years and should be no problem. Well, first of all, the new fire door inspection that's required requires a trained individual with documentation of training and is looking at a plethora of items that must be inspected. I never knew there were so many things on a fire door for a person to inspect, but talking with some of the companies that do this for a living, they claim it takes between 15 and 20 minutes per fire door to do the inspection. So by that, it's more than just making sure the door closes and latches. which is and the proper clearances, which is what we typically check during that building maintenance program. So no, we need to do a little bit more than that. As a matter of fact, there are some states that are saying that any rated door must be inspected, whether or not that door is required. I was at a hospital recently where the door to the engineer's office, because they renovated the engineering department some time back, they put a 90-minute rated door in his office. No reason to have it there, but there are some states that are saying that because that 90-minute door is on his office, it must have all the requirements that a 90-minute door would require to have, and even though it's not it's in a non-rated wall. So how this is going to play out across the country is going to be interesting to see just how it's done. But basically, it is a much different inspection, this fire door inspection.
Great. Scrolling through the side over here at some other questions. Let's see. I think there's a good one here. I know you mentioned earlier that Life Safety Code Chapter 43 allows us to convert a patient room into a storage room by adding just a door closer. Does this require a 45-minute rated door? I know this is might go a little bit along with the last question, but does it require a 45-minute rated door and 1-hour rate walls from deck to deck?
Quick answer, no. And that's what's nice about this new Chapter 43. It says that if the space that we're converting, if it's less than 250 square feet, we don't have to comply with the new healthcare occupancy requirements of the code. We can simply follow existing healthcare requirements. So that's a huge benefit, for us, because often we have to convert a space from one thing to another, usually into storage, and to upgrade the walls and replace the door with a labeled door and so forth is very expensive. So this is very good for hospitals.
Absolutely, could not agree with you more there. We have, about used up all of our time, so we're going to address one last question here and then go ahead and wrap it up. Had a great question come in. I know that you noted earlier that the number one Joint Commission finding in the first half of 2016 was a safe and functional environment. What kind of things would this finding include?
Okay, I mentioned a few things. Sold utility room, pressure differentials, temperature and relative humidity not being recorded in some of the spaces, ORs, sterile processing. But it also includes if we are not properly segregating our oxygen E-cylinders. This is a little bit of a catch-all standard. So it picks up anything in the functional environment that may be a concern. So I've seen even soil ceiling tile placed under this one. But I think the big thing that has caused this to be so high on the list, well, first of all, probably because it covers so many different issues, but we're seeing a lot of the temperature, relative humidity, and pressure differential issues also hitting here.
Awesome. Well, Wayne, thank you so much for taking us through that brief Q&A and the entirety of today's presentation. I mean, I know the audience definitely agrees with me when there's been a ton of extremely valuable material covered today. So thank you to you and your time today for taking us through that. We really do appreciate it.
I enjoyed it. Anytime.
Yeah. Well, thanks everybody else for joining us. We appreciate you taking time out of your day as well. Hope you got out as much of this webinar as I did today. Just listening in, I feel way smarter. But we certainly hope that encourages you to join us for future events. So I hope to see you back soon. Thanks.